Good morning, everyone, and welcome to the 19th Annual Mario Sforani Memorial Lectureship. Before we get started today, I'd just like to tell you that you can join by texting questions to DeBakey 37607 as the talk is going on, and we'll certainly answer those questions at the end of the lecture. I would like to say a few words about Mario Sforani, who this lectureship is about. Dr. Sforani was Director of Nuclear Cardiology here at Methodist for some 17 years. He was a prolific writer and researcher and wrote over 200 publications over his career. He actually was one of the ones who spearheaded pharmacologic stress testing and the use of adenosine for nuclear myocardial perfusion imaging. He was an incredible educator and scholar. He was an ambassador and spokesman for nuclear cardiology and for cardiology in general, and was an international and national speaker across the globe. Of note, he was also an incredibly caring and competent cardiologist and clinician, very dedicated to his patients, and indeed that probably helped a lot in terms of his research endeavors. Mario was also one of the founders of the American Society of Nuclear Cardiology. He was past president of the American Society of Nuclear Cardiology. And on a personal note, he was actually my mentor and my colleague and friend for many years. Mario is truly a genuine, caring, and despite all of his major accomplishments, such a humble individual. And this is why we have this lectureship for him today. I would now like to say a few words about our speaker, because our speaker is who I've known for some 35 years, dating back to 1985 when nuclear cardiology was just starting to get going, and so much innovation and excitement was in the field. Dr. Daniel Berman, really a truly remarkable individual, the father, one of the major fathers of nuclear cardiology, someone who has also spearheaded and been a pioneer in cardiac CT. Dan has always been one who has never been afraid to reach out and integrate imaging techniques. He was never married to nuclear cardiology alone. He was always looking for other ways and avenues to develop and integrate imaging technologies. And that's reflected in all of his publications, too innumerable really to even count, in both nuclear and cardiac CT. He's also the past president of the Society of Cardiovascular CT. He's been a thought leader and innovator in the field for decades now, literally decades. And in fact, he was one of the drivers of the ISCHEMIA trial, which he is going to talk about today. So Dan, it's an absolute pleasure having you here today. I know it's only 6 a.m. in LA, and we really appreciate you getting up so early to talk about the ISCHEMIA trial and its implications for CTA and myocardial perfusion imaging.
Well, John, thank you very much. It's the second time I'm giving a Mario Sforani memorial lecture. I did it for ASNIC before. My talks changed a little bit, but not that much. I think it was 2007. And at that time, I was well into the multi-modality imaging and was talking about how CT is coming to the fore. And that has really happened. Mario was very dear to me, and everything you said about him truly characterizes the man. This man was a gem, and we all miss him very much. He taught me a lot. And I know he taught you and countless others. So it's really an honor to be giving this talk, and thank you for the kind introduction. So I'll go ahead and share my screen and start from there, but that didn't work. So now I gotta go back and I'll share my screen. But first I'm gonna put up this. And then I'm going to go here, and I'm going to go to share my screen, and then I'm going to put up this, and I'm going to share, and we're here, right? Okay. Zoom. I think this is my first major Zoom talk, believe it or not. So bear with me. My disclosures are that I participate in royalties from Cedars-Sinai, and as John mentioned, I was involved from the beginning with the ischemia study and was the director of the ischemia nuclear cardiology core laboratory. So to give a little background into this important trial in stable coronary artery disease, we have to think about the patient. When the patient comes in with symptoms, the patient's questions are, what's causing my chest pain? Can you relieve it? And am I going to live? Am I going to have a heart attack? But the relief of symptoms is high on the patient's list to improve their quality of life. So starting off with a case, this is a 78-year-old man who presented with what sounded like angina, but it wasn't definite because of its left-sided nature and unclear precipitation with exercise. Multiple risk factors and under good medical therapy for presumed coronary disease, although it was not proven at that time. Here is his PET examination. Sorry, this was a rubidium PET study demonstrating a severe reversible defect throughout the lateral wall, consistent with a large territory of ischemia. We see it quantitatively on the right, and with what we call the ischemic total perfusion defect, or TPD, of 26%. This is a very large amount of myocardium. Some of the patients in the ischemia trial had this, although most were closer to the moderate to the lower edge of the cut point. And with that, he was capped, and he had multi-vessel coronary disease, particularly involving the left circumflex and the right, but it was also involved the LAD, had triple the bypass, and was pain-free 3 weeks after surgery and remained pain-free up until this day. So first, we should think about, well, is ischemia itself dangerous? We know that plaques are dangerous because of the rupture, but is ischemia dangerous? And just to look at that kind of unusual question, is that ventricular fibrillation or something like that very important? So we look at a recent article in Circulation in which 2,122 patients admitted to the hospital were studied when they had troponin elevation. 1,500 of these patients had a myocardial infarction, and of those infarcts, almost 29% were type 2. They were oxygen demand, and without enough supply types of infarction. The outcomes, whether it was just myocardial injury, type 1 MI, or type 2 MI, for cardiac death or non-fatal myocardial infarction was the same between the groups. And when they looked at the type 2 MIs, coronary heart disease was a strong independent predictor. So ischemic heart disease is an important underlying factor in this prominent type of myocardial infarction. So ischemia is bad, but can we fix it, or can we improve outcomes with revascularization therapy? This slide just summarizes many of the well-known studies looking at medical therapy versus PCI. These are the randomized trials. And we see that in some, putting all together, they showed a neutral response. There was no benefit on these early trials. In general, there has been no hard evidence of outcome benefit with revascularization in large trials. And this even includes the FAME trial, in which there was an overall improvement in outcomes. This is the short-term outcome and the 5-year outcome. However, even in the 5-year data, there was no difference in death or myocardial infarction, the hard endpoints, in the revascularized arm compared to the medical therapy arm. So this, the prior trials, because Spain wasn't yet out, but the prior trials and beginning to see, I think the FAME had just come out, were the backdrop of the concept that we needed a new trial, because a paradigm had been set up in our guidelines to say that patients with moderate to severe ischemia should be going to the cath lab. And although prior studies had been based on ischemia, none had been based on just looking at patients before they went to the cath lab. So for over 50 years, stress testing has been used to guide decisions for invasive management of patients with suspected or known coronary artery disease, beginning with the stress the EKG, and then for nuclear echo and CMR. But the evidence to support it has come primarily from observational registries. Now, this slide comes from our work in 2003 by Rory Akamovich, studying 10,000 patients at Cedars-Sinai with SPECT imaging, looking at outcomes. This is a very commonly used slide where we see that there's a outcome for it. This is the log hazard ratio for cardiac death, medical therapy on the top in red, revascularization on the bottom. We see two lines that cross, indicating there was an improved cardiac death outcome in the patients who had extensive ischemia in this study. Now, they crossed right around 10%, and that became the basis of the ischemia trial. But if you look carefully at where the lines cross at the 95% confidence intervals, they're actually right at 15%, which in retrospect may have been a more appropriate the threshold for entry into ischemia. We then took that same data forward with long-term follow-up, expanded somewhat, and published this in the European Heart Journal in 2011. Again, Cedars data by Hakamovich, and we see a similar pattern displayed differently. But when we look at this study, we see that the 95% confidence intervals cross at the 95% confidence interval cross right at patients who had 15% ischemia, not in patients who had 10% ischemia. That line horizontally is right at that no benefit level. So the limitations of these prior data, which were those data available at the beginning of the trial, were that they were retrospective, coming from one center. They used guideline. There was no standardized therapy in the trial. It's older. It was from the 1990s. Angioplasty wasn't so good. Medical therapy wasn't as strong. So it was older data. Unmeasured factors could not be accounted for, and there's residual error even with robust adjustment. It may not completely account for biasing. So that was the backdrop for saying we need a trial looking at patients who've undergone ischemia testing to see whether that 10% threshold for ischemia that was derived from our initial study led to improvement in outcome. So the research question of ischemia was, in stable patients with at least moderate ischemia on a stress test, does cardiac catheterization with the intent to revascularize improve outcomes when added to optimal medical therapy? Here's the outline of the trial. The patients came in with testing that showed moderate to severe ischemia. This was determined by site and later verified by the core laboratory. They then underwent a blinded coronary CT angiogram. And this was performed because initially, I was sitting at the back of the room in the organizing meeting. I questioned, will doctors be willing to randomize people who they think might have left main with this severe ischemia? So the blinded CTA was put into this large multi-center randomized trial to rule out left main and also to rule in some obstructive coronary artery disease. If they had, then they went to the cath lab. Then they were randomized to invasive versus non-invasive therapies. Exclusion criteria important: left main greater than 50%, a very low EF, very abnormal renal function, a recent acute myocardial infarction, unstable angina, or unacceptable angina, I should say, was important, because if a patient had accelerating angina, the likelihood a doctor is going to randomize with 10% ischemia goes down. So these were exclusion criteria for the trial. There were 109 patients randomized in 320 sites in 37 countries, an enormous trial. The primary outcome was time to a composite outcome of cardiovascular death, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. Secondary events were time to cardiovascular death or myocardial infarction, as well as quality of life. The baseline characteristics of the study in terms of angina are important because what we see is that approximately 50% of the patients were class 2, and approximately a third of the patients had no angina had actually no angina, and in terms of the angina described by the Seattle Angina Questionnaire, there was a significant fraction, about a third, who had no angina or minimal angina in the prior month. The baseline variables of the study just illustrated, these are just what medications they were on, that there was very effective therapy. These were already very well treated patients with statin and aspirin, almost universal. And when they found out whether the patients were really taking the medications, with 81%, with 74% adherence at baseline, going up at the end of the trial to over 80%. So during the trial, very careful, managed, optimal medical therapy was achieved in both arms. In the core laboratory reading of the patients in the ischemia trial, there were almost 38% of the patients who, by various modalities, I should point out, is predominantly nuclear, secondarily echo with a very small amount of CMR for the imaging part, and then a substantial fraction of the patients from India and China enrolled with ischemia testing by stress ECG alone. There were in the trial patients after core laboratory reading who did not have moderate or severe ischemia for almost 15% of the patients. The main data of the trial are shown here. This is for the composite outcome, the invasive arm red, the conservative arm in blue, and there was no significant difference in the adjusted hazard ratio. Early on, there was a higher event rate in the invasively treated patients. Later on, there was a higher event rate in the conservative patients. The lines appear to be diverging, and although the effect was at most modest, there will be a continuation, an extension for long-term follow-up of the study. The major secondary outcome, one of them was cardiovascular death or myocardial infarction. This was interesting in that there was a significant increase there was no difference overall in this endpoint, but when looked at early on, there was an increase and then a decrease, similar to the overall trial. But what's driving this was increase of spontaneous MIs early and of procedural events early and then spontaneous events later. Importantly, in the overall trial, the therapy was excellent, and the all-cause death rate in the conservative arm was 1.66, much lower than was expected in the trial. This slide breaks down, looking at the various different types of factors that might have led to important secondary analysis. But when it was looked at from a standpoint of imaging, or overall, there was no heterogeneity of treatment effect for any subgroup. And when we looked at the ischemia data, again, nuclear, echo, and CMR, there was a trend towards patients who had moderate to severe ischemia having a beneficial outcome, but that was not significant. Appeared to be slightly lower in severe ischemia, that's over 15% or more, but it didn't cross the 95% confidence interval. And then we also noticed that looking at the CT severity, one vessel, two vessel, three vessel disease, there also was no difference in the composite outcome. But it's interesting to see that both of those were trending in the same direction. So not yet assessed from the trial is data by modality, where the modality methods of looking at ischemia differ in terms of outcome, and whether combining the anatomy with the moderate to severe ischemia is associated with better outcomes. And this relates to an overall concept that we have, that it's the combination of anatomic findings, such on a nuclear scan could be derived from a calcium scan, a combination of the anatomic findings with ischemia findings is probably optimal at this point in evaluating patients with suspected coronary disease. Looking at the outcomes in terms of quality of life, interesting data emerged. There was a significant benefit in ischemia measured by the Seattle Angina Questionnaire in the invasive therapy arm that was present at 3 months, again at 12 months, and persisted 36 months after randomization. However, in the patients who had no angina, there was no benefit in the revascularization therapy for the first 12 months, and didn't even reach significance at 36 months. And when you look at these probabilities graphed in a slightly different way, we see that the main benefit that was observed is in the patients who had the worst angina, and there was very little benefit in the patients who had little angina in terms of quality of life, as we would expect. So the results can be summarized with the invasive strategy. Patients with moderate to severe ischemia, in patients with moderate to severe ischemia, there was no reduced risk of the composite outcome, of the secondary outcome variable of death or myocardial infarction, more procedural MI, fewer spontaneous MIs, but a sustained improvement in angina and quality of life with no heterogeneity of treatment effect. Well, this major undertaking, major large trial, really does contribute to our knowledge about ischemia and the relationship to a strategy of catheterizing patients or not. It's a larger population than in prior randomized trials. It's randomized on the basis of the ischemia rather than at the time of the cath, such as in the other trials that have already been performed. There was core laboratory interpretation of the data. There was excellent optimal medical therapy, follow-up nearly completed everybody, and rigorous adjudication of events. Limitations are, as with all randomized trials, is there's a selection bias towards the least sick patients. In the patients with 10% ischemia, particularly in the United States, there's some discomfort in physicians in randomizing patients with that much ischemia, particularly if it's recent, so that the kinds of patients with moderate to severe ischemia who get into a trial are less sick. 34% had no angina last month, and only 29% had new or changing symptoms in the last 3 months. As I mentioned, about 14% not core lab eligible. Importantly, the left main disease was excluded. Those are the patients where non-invasive testing might be more important. they made up a substantial proportion of the patients who were enrolled in the trial. So I think the overall implications for medical practice is that we're going to realize that medical management is a reasonable therapy in patients with moderate to severe ischemia. And the use of optimal medical therapy alone as an initial choice will increase. Now, with that as a backdrop, I'd like to look at what the implications of this important trial are for the non-invasive testing techniques that we utilize every day and were used in the trial. I think that the overall point I'll make is that ischemia will accelerate current trends in the use of CTA and myocardial perfusion imaging by any of the modalities. Just to support that concept, what we see in our own laboratory is shown on this slide from 2006 to 2019. And we see that there is, in the yellow color, calcium scan, a very important test for evaluating the global burden of coronary atherosclerosis, rising dramatically in basically in the general internal medicine practices as well as in cardiology. Strong predictor, should be included when we're doing a SPECT study or a PET study. We have then a rise in coronary calcium testing, a definite rise over this period of time. We started CT right around 2005, coronary angiography in our lab, and we see it's been going up and really has turned up now quite a lot in recent years, and is starting to approach the numbers we have for calcium testing, but we don't have the capacity to study all the patients who are referred. We see in the SPECT world that we've had about a 30% or so decline in the use of SPECT in our laboratory, and a modest increase in PET scanning that has recently ticked up. So we're doing a higher proportion of our patients for myocardial perfusion imaging with nuclear with PET at the present time than we did before. This is the kind of patient who got excluded from the trial. The 64-year-old man sent for coronary CTA with non-anginal chest pain and a positive family history, where we see a clear-cut, severe left main stenosis, who gets eliminated from the trial because of the left main, which was confirmed at CAP and fixed. So left main was excluded in the COURAGE trial, in the Berry 2D trial, and in the ischemia trial. And 5% plus 5.8 of the enrolled population in ischemia were excluded because of this most severe kind of anatomic disease on the basis of their coronary CTA. So now let's turn more to the stimulation behind what's causing CT to grow. First, this is a test with very high sensitivity, modest specificity, but high sensitivity. This recent meta-analysis in the British Medical Journal demonstrates that this is that the specificity of coronary CTA is not as high as we'd like, but it's very high sensitivity for detecting here just obstructive coronary disease that's greater than 50% stenosis. But we all know that doesn't necessarily, often 50 to 70% lesions don't cause ischemia, probably in the most, in the largest group. As per the FAME studies, in the majority of the patients, 50 to 70 doesn't cause ischemia. So we've turned to using a fractional flow reserve in the cath lab as the current gold standard for ischemia. And meta-analyses have been done of the data from the non-invasive technologies. This slide showing meta-analysis from SPECT, echo, MRI, PET, and coronary CTA. And what's observed is that coronary CTA had a very high area under the curve that was similar to what was observed for PET and SPECT for predicting FFR ischemia in the cath lab. Then augmenting CT further is now the ability to look not just at the anatomic disease, but also at a measure of its functional significance. So the technique of FFRCT, or fractional flow reserve by CT, measured to detect lesion-specific ischemia, has now come to be a validated and reimbursed technique that allowed us to be able to take patients with LAVs with only moderate perfusion, obstructive disease on CT, and to separate them into by the basis of their FFRCT. The top one has a moderate stenosis with a low FFR, and the bottom one a moderate stenosis with a normal FFR, just for examples. And what we saw from the largest of the trials using FFRCT early on, this was called the NXT trial, that what CT FFR did was it improved that specificity. Here in the salmon color is the specificity of CT for greater than 50% for ischemia. And even the CAT 50% ischemia had very low specificity, but there was high for predicting FFR, but there was high now specificity using the FFRCT method. Paul Knappen in the Netherlands has taken this a step further, where he was able, as an interventional cardiologist, to randomize 208 patients for 3 vessels FFR after they had had multiple non-invasive tests. And what he demonstrated was that the FFRCT plus the CT had the highest ROC for predicting FFR ischemia, and SPECT of the methods that were used, which were PET and SPECT and FF and CT, had the lowest. That's the overall data, but on an intention to diagnose, PET was actually superior because 17% of the vessels could not be analyzed by FFRCT, such as those with dense calcification. Now, CT has been known for years to have excellent prognostic value. Here we see it for the normal scan, a very long warranty with a very low event rate. Non-obstructive disease that's picked up has a much higher event rate, as we know. And then single, double, and triple vessel disease, with each increasing category, the outcomes worsen. So prognostic data, very strong with CT. Then when we look at a recent trial called the CONSERVE Trial, begun by Huck-J. Cheng and James Min, what they did was to randomize patients to who were on the way to the cath lab for guideline-indicated reasons, stable patients, to go ahead and get their cath or have selective catheterization following a CT examination. There were about 1,500 patients, and it was almost 50-50 between the arms. They were followed for hard outcomes as well as for costs. The MACE rates were the same between the conservatively handled group, no ICA, compared to those who had ICA. And then looking at the overall effect, the proportion of patients who went for cath had a 78% reduction, the proportion who were revascularized, a 31% reduction, and there was a 50% reduction in costs. So pretty strong data indicating that CT can be an effective gatekeeper to the cath lab, even in the days before FFRCT was applied. And CT has also been shown in some early work from the CONSERVE trial, to, by the extent of disease, be able to have this prediction of outcome that we saw in the SPECT data, where patients with 2 or 3 vessel disease had better, lower mortality rates if they underwent revascularization in this observational registry compared to those who underwent medical therapy. An important study of fostering the growth of CT is the Scott Hart trial. This excellent study, published in the New England Journal by the PI David Newby, has really substantially changed the view of cardiac CT. And what they did was they randomized patients in what they call urgent care centers, where patients with chest pain go in Scotland, they took 4,100 patients and randomized them to a standard of care and to a standard of care plus coronary CTA. Now, 85% of these patients in both arms underwent stress testing. So again, we're dealing with anatomic and with functional data. The endpoints included the diagnosis of coronary disease, changes in therapy, changes in investigations, and importantly, the prediction of death or myocardial infarction. Well, the outcome of death or myocardial infarction at 5 years was seen to be markedly improved in the patients who were in the CT arm. And it was driven by a reduction in non-fatal myocardial infarction. There was a 60% reduction in myocardial infarction a 40% reduction in myocardial infarction in the CT arm, CT plus exercise, remember, compared to the standard of care arm. There was no 5-year difference in revascularization. There was more early revascularization potentially impacting this data and less late revascularization. Overall, no change, but there was clearly much more preventive therapy in the patients who underwent CT. And I would maintain it also might have been fostered if they had used calcium scanning alone in terms of changing therapy. Well, this trial and the prior data, but particularly this trial, influenced the 2019 European Society of Cardiology guidelines quite dramatically. And what we see is now, instead of having the ischemia testing alone with a class 1 indication, coronary CTA was added as a class 1 indication in patients who were suspected of having coronary artery disease. They also, that was for diagnosis and is also recommended with a class 1 classification to assess risk. Now, these apply both to the functional testing and to CT, with the risk assessment being on the test that was used for diagnosis. Those prior data accelerating the field dramatically. But around the corner, we have another aspect of CT that is going to further accelerate the use of CT, because it's really the plaque, the rupturing of coronary plaque that leads to the myocardial infarctions. And these are not all going to be treated by angioplasty. And we know that there are characteristics of plaque that we find are characterized, the high-risk plaque, as has been shown invasively in the PROSPECT trial. But these features include many that can be measured by CT, including the low attenuation plaque, which represents the necrotic core, the inflamed necrotic core, which is a big offender for plaque rupture, positive remodeling, the size of that plaque, spotty calcification, and a thing called the napkin ring sign, in which this large necrotic core essentially is encapsulated in at least moderate calcification around the vessel. And there are further data that might suggest that even CT could be looked for inflammation. But plaque assessment with CT is going to become central in the evaluation of CT. These are data from 2007 by Jagat Narula's laboratory, where the size of the plaque was seen to be very important. And the two features that they looked at for adverse plaque characteristics were positive remodeling, outward bulging of the artery from these large plaques, and low attenuation plaque that represented that necrotic core. Now, multiple studies have looked at the combination of stenosis and high-risk plaque in predicting hard cardiac events. And in each of these studies, it was seen that the combination of high-risk plaque features, HRP here, and plus stenosis was associated with the worst outcome, whereas having neither stenosis nor high-risk plaque was the best, one of the other in between. All three of these studies consistent. Patients who had plaque high-risk findings and stenosis are the ones who did the worst. And this was based on visual analysis alone. consistent evidence. But CT has the ability to be analyzed quantitatively, and I'm really quite fortunate at Cedars-Sinai to have within our group previously and now in our completely independent group extended to a great deal, essentially from the beginning to current, everything that can be done with plaque assessment by CT, even including the look at inflammation from the pericoronary adipose tissue that's shown in the lower right. So extensive literature has come from Dominique Day's laboratory. And what it boils down to as the most important variables that she's measuring quantitatively is percent stenosis, the various plaque types and their burden. Importantly, that low density plaque representing the necrotic core, the remodeling index, something called contrast density difference, which occurs across the length of an artery and relates to ischemia. Here's a case example, a 75-year-old man with angina who by CT is found to have a large plaque in the proximal LAD. We see it as a very large plaque with positive remodeling and low attenuation plaque. That's the napkin ring sign. And then the FFRCT that confirmed the findings of a severe ischemia-producing lesion in the LAD. But what Dominique Day has shown is that she takes her own quantitative analysis of plaque and then analyzes it for all of the information that can be derived through machine learning, that when she applied it to the NXT data or the FFR data that was used for FFRCT, she found that there was a very high area under the curve for plaque alone in predicting ischemia by FFR. More recently, this approach has been applied to the Scott Hart trial. We went back and looked at the data using now this plaque measurement and found that the patients who had the lipid content within their coronary plaque had a much worse outcome than the patients who did not. And it was these patients who actually made up the patients who were the ones who were having that dramatic improvement in the rate of myocardial infarction. So this paper from Circulation 2020 really takes the whole quantitation of plaque burden, and particularly at that non-calcified plaque, a step further in being able to predict risk. The only significant predictor considering cardiovascular risk factors, stenosis, and calcium, and total plaque burden was the lipid burden in the plaque. Now, the greater the stenosis, the greater the event rate, but after factoring in all factors, it was low attenuation plaque burden. So CT will positively affect, in the ischemia trial, I believe now, added to all those other factors, continuing increasing CT growth will positively impact the study. In patients with coronary disease and angina, there will be, I believe, an important need to rule out left main coronary artery disease or critical proximal LAD disease that will be used in deciding whether medical therapy is okay or not. It adds to the trends that are favoring the use of CT, the Scott Hart trial, the guidelines, the functional assessments that I mentioned, the emerging recognition of the importance of plaque and the possibility of machine learning being applied to it. There are factors that will slow this expected impact of the trial. We have decades of ischemia-guided management. We have the lack of availability of high-quality CT examinations. They're difficult to perform. There are a lot of artifacts when in the growth curve when you're learning how to do it. We don't have enough equipment for it. You need the highest level CT scanners, not enough technologists to perform the studies well. And the difficulty in interpreting scans that come with the various artifacts, and particularly high calcium, even among experienced observers. So turning to myocardial perfusion imaging, what do I think will be the impact? Ischemia will accelerate the current trends in myocardial perfusion imaging. Another scientist I'm fortunate to work with at Cedars-Sinai is Piotr Slamka, and Piotr has established a very large registry. It's going to be 32,000 patients shortly, in which he has applied a totally automatic approach to analyzing myocardial perfusion SPECT data and applying machine learning and deep learning techniques to this analysis. An important paper was published in JACC Imaging from our group that mirrors the paper by Akamovich years ago. Now in a larger group, it's 17,000 patients, 5 centers international, including in international centers. Data is recent, it's not the old data now, with the more modern therapies. Nearly a 5-year follow-up, MACE occurred in 1,500 patients. And these data are adjusted in a similar fashion to the way we adjusted data in the early Akamovich study. What's seen is these curves shown in a reverse pattern in which they show the relationship between the log hazard ratio for outcomes, including MACE events and all-cause mortality, and ischemia. And we see that these curves cross right at 10% ischemia. So in this large randomized trial, large modern registry, the benefit of ischemia, of revascularization in patients with ischemia now has been borne out. So it's not just old registry data that demonstrates this. And importantly, when we think about SPECT, it has the advantage of being able to be combined with exercise. And both PET and SPECT can be combined with calcium scanning that I think is going to even improve that kind of data. Now turning to PET, Krishna Patel from Tim Bateman's group has recently shown us that PET perfusion defect assessment, looking at the percent myocardial ischemia, demonstrates similar findings, where right around 10% ischemia, there appeared to be benefit with a revascularization therapy in terms of looking at all-cause mortality. Similar data to what we demonstrated recently with SPECT. And they carried that a step farther by taking advantage of the ability to measure myocardial flow rates with PET. So we look not only at the overall ischemic burden, but what is the myocardial flow reserve, which has been shown to be so important in adding to the ability of PET to predict outcomes, and was the basis of that data that I showed you in Knappen's Pacific trial. And what she found, which is Krishna Patel, is that the lines for medical therapy and revascularization again crossed, pardon me about that, they again crossed right at that level of about 10%, right at that level of a 1.8 for the coronary flow reserve. And once that was known, then the amount of regional ischemia had only a minor effect on that outcome. Now, when we think about it, as I've been hinting through this study, we can take patients who have mild defects on a PET scan or on a SPECT scan and reclassify them on the basis of what they have in terms of calcium scanning. How much atherosclerotic burden do they have? Here we see a patient with a mild ischemic burden, but who has a 1,400 and coronary calcium score in the 97% level, suggesting that he has more extensive disease than shown by simply the perfusion defect alone. And this patient actually had left main coronary disease. The potential of ischemia testing plus calcium compared to coronary CT has not yet, regarding outcomes, has not yet been tested in a randomized trial. We have the PROMISE trial comparing non-invasive testing to CT, but not including calcium. And this has not been yet tested. But let's turn back to the patient now and talk about not only improvement in outcomes, but again, improvement in their quality of life. And I demonstrated that with the ischemia trial, there was this improvement. Here's an example of a patient whose data I really don't have time to go through in order to have questions answered, but there was too much calcium on a coronary CT to interpret it. We tried. We called it a lot of defects, and this is actually my interpretation, 270% stenosis. And then went to the cath lab, and the coronaries were entirely normal. But when she still had her chest pain and came back for a PET scan, we found that their coronary flow reserve was completely normal, suggesting that her chest pain was not due to myocardial ischemia, completely normal flow reserve. So what is CFR or MFR, the myocardial flow reserve, doing compared to FFR? It's looking at the entire macro and micro circulation. And it's the ultimate perfusion of the heart, which is really governing whether the chest pain patient's going to get chest pain or not just the epicardial coronary arteries. FFR doesn't assess diffuse atherosclerosis, microvascular dysfunction, or collaterals. And the dynamic perfusion methods with PET or CMR or dynamic CT perfusion and potentially SPECT do measure them. So we have increasing interest now in the patients with INOCA or ischemia without obstructive coronary artery disease. And we know that that is a source of worsened outcomes and certainly a source of chest pain. That's a patient who had it. This is a patient with normal coronary shown to have abnormal flow reserve by MRI. And here's a slide showing it's that in the patients who have normal coronaries but abnormal flow reserve, either in the cath lab or with coronary flow reserve measurements by PET, there is this worsened outcome. So then, what do I think is the relationship of the ischemia trial to the myocardial perfusion imaging methods? And overall, I believe it will have a negative impact, but this negative impact will be reduced by many factors. One is trial limitations, particularly selection bias that I mentioned of the less sick patients. The overall less than expected impact of randomized trials on clinical practice. The limitations of the ischemia data in the with nuclear data within ischemia, site interpretation of the overall population, limited use of two-view or attenuation corrected imaging, which we know is so important for improving the assessment of ischemia with SPECT. Rest and stress wall motion and ejection fraction determinations done in only a minority of patients. And it was consensus visual interpretation, which was quantitatively guided by the total perfusion deficit, but it was an overall visual interpretation that was used of the myocardial perfusion imaging, not that automatic analysis, and certainly with no clinical or ECG information to be able to add to the assessment. There was minimal PET measurements and no assessments of flow in the study, and minimal, very small number of patients had CMR. And these didn't take advantage of the specific strengths of myocardial perfusion imaging, and the specific strengths that are going to reduce the negative impact are its continued recommendation in guidelines, the evidence of recent observational studies that I've shown you from the data of Slumka's lab with SPECT and Bateman's lab with the revascular with PET and Patel and PET, I should say. Its wide availability, essentially all around the world. Its ability with PET to determine the cause of symptoms through flow reserve, even microvascular disease. The increasing population is with contraindications to CT, the increasing use of calcium scanning plus myocardial perfusion imaging, and its use in evaluation of borderline studies. The conditions in which stress imaging will remain the test of choice: technical limitations or contraindications of CT, lack of availability, known borderline findings, and whether you have to assess the outcomes. High calcium, renal failure, arrhythmia, morbidly obese, unable to hold their breath. These are patients CT has a great deal of difficulty with, where myocardial perfusion imaging has none. So to end, what I believe are the conclusion, physicians are going to become more comfortable with medical management as a choice in patients with moderate to severe ischemia. The use of coronary CTA will be positively impacted. Left main coronary disease many will feel the need to rule out left main coronary disease as the most important added value of CT in the angina patients. And it'll add to the other factors which are working in CT. The use of SPECT and the myocardial perfusion imaging in general, negatively impacted but mitigated by that with SPECT imaging. This comment is guideline support, lack of the infrastructure for the other modalities, the CT limitations, and then finally, I think that the use of PET and CMR with flow measurements will be less effective. So thank you to my excellent team for giving me some of the data that allowed me to make this presentation. And thank you very much, John, for the invitation to be able to participate in this Mario Verandi Memorial Lecture.
Great, Dan. That was an absolutely fabulous talk regarding where we stand today in terms of evaluating ischemia and predicting outcomes using all these different modalities in light of the ischemia trial. I think from my perspective, I would like to get your feelings about the different populations that we study, because I've always felt that if someone's asymptomatic with risk factors, then calcium scoring is the way to go. If someone's low risk with atypical symptoms, that maybe CT is the first line test, because you exclude disease and maybe just find non-obstructive disease that you can readily then treat aggressively. But in the more intermediate to high risk patients, and particularly those who have prior bypass procedures or stents, then myocardial perfusion imaging, and particularly PET, are more the way to go. So I'd like to get your feeling in terms of where we stand on that. The other thing I'd like to just mention is that in the Scott Hart, as powerful a trial as it was, it only used stress testing. It didn't use myocardial perfusion imaging to predict outcome. And what's also interesting about Scott Hart is that when they looked at all of the major angiographic predictors of risk, including calcium scoring, that calcium scoring was actually the best independent predictor of outcome. And that, of course, can be readily added to PET or SPECT on today's current system. So I'd just like to get your feeling about those issues.
Well, as you know, those comments integrate completely with my thinking, and you and I have been in sync with our thinking from when I first met you. The exact outline that you described was part of my initial Mario Verandi lecture. For preventive purposes, calcium scanning is all you need. In the lower risk patients, CT is the way to go, and in the higher risk patients, then myocardial perfusion imaging or some stress imaging modality would be the best. Now that's prior data, but with the ischemia trial, now we have patients with a lot of ischemia. They're obviously high risk. They're patients with disease, and we see the potential application of CT in ruling out the disease, the left main and potentially proximal LAD disease that is going to be the most concerning. So that might extend the application in the higher risk group. With respect to Scott Hart, yes, they only used exercise testing, and it might have been different if they had used something like myocardial perfusion imaging. And in fact, the calcium scanning in their data was extremely important. And they believe that most of the impact of their trial in reducing infarcts was from the change in preventive therapy and medical therapy rather than in the revascularization. So what they're doing right now is they're going to reanalyze the data, but I'll take it a step farther. When Dominique Day, what is actually Michelle Williams, working with Dominique, did this plaque assessment of the coronaries with the CT. Then calcium no longer was a strong predictor. But I believe what we're going to see is that we're going to have calcium scanning become a routine part, is already a routine part of PET. It should be a routine part of SPECT. And as I mentioned, I don't think that that combination, it's never been tested against CT, and it'd be hard for a CT to be able to beat it in the patients with the higher risk.
Yeah, no, I totally agree with that assessment. The other thing that's kind of interesting, and you didn't talk about PROMISE, but it is interesting that in PROMISE, which really compared functional testing, most of which was myocardial perfusion imaging versus CTA, there was twice as much revascularization in the CTA arm without any benefit in terms of outcome. And again, knowing anatomy can sometimes push you to do things that really aren't warranted. So I think, we still have a lot to learn.
Really a mistake for me to have left out PROMISE. You were such a prominent person in the PROMISE trial. Yeah, they were equal, but in that trial was very early in CT, and their CT studies weren't so good, and their interpreters weren't quite as familiar, and a lot of patients went to the cath lab. That recent CONSERVE data that I showed you with the dramatic reduction in caths is pretty interesting and might have had a bigger impact on a new PROMISE trial.
Right, great. So we have some questions from the audience. First of all, I have one question. Was the presence of TID, RV uptake, drop in EF recorded for nuclear stress tests in the ischemia trial? And if so, how often did that occur?
I don't have the data. We have not separately analyzed the nuclear part of the trial. We had to either choose, a problem that we had was that there were many different kinds of scanners and many different protocols for SPECT. It was not mandated at all. Most of the SPECT imaging was just retrospective, picked up from generally from a report at the time of referral. So most centers don't do rest ejection fraction. So we don't get rest stress while motion abnormality. We don't get ejection fraction drop that's now become part of routine SPECT analysis. And as I mentioned, we didn't have prone imaging or attenuation correction. So it was, there were problems with potential artifacts suggesting the presence of ischemia, and we didn't have the high-risk markers available. We do have a TID. It's a visual assessment that's transient dilation. It's a higher risk market, and that will be available for analysis. It hasn't been looked at yet.
Yeah, and I think I was kind of intrigued by some of the subgroup analyses so far in terms of none or mild versus moderate versus severe perfusion abnormalities, and whether there might be some kind of signal showing that once you get into very high degrees of ischemia, that maybe in the ischemia trial people would have benefited more. We'll see. I think that's just food for thought. Another question is,
there probably is going to be an ischemia threshold above which I shouldn't say probably. There could well be an ischemia threshold with apparent possible benefit that we haven't analyzed the data yet.
Yeah, and I guess one of the issues is that medical therapy keeps getting so good that it may really limit the ability to show the benefits of revascularization beyond, suppressing angina. One other question from the audience: do you think calcium scoring can be a gatekeeper for SPECT MPI?
Well, I think I have a colleague in Houston who thinks that's not a bad protocol, named John Marion. Maybe an exercise, what Alan Rosansky, my colleague, calls it is the calcium treadmill. So combining standard exercise testing with a calcium could be a screen even in patients with chest pain, but that's a little far out, and it is going to miss some patients, and it's not rare for us to see low calcium scores in MIs, and extensive disease. So that is the problem.
Okay, great. Let me see. One other question, could the use of DAP beyond 12 months in the invasive arm explain the observed reduction in spontaneous MIs in the ISCHEMIA trial? I think that's food for thought. I don't know that that's something we can really address at this time. So Dan, I think overall, one last question, because we're all, it's very provocative in terms of FFRCT, and I'd just like to get your feelings about it because, there are a lot of limitations for the use of FFR. Obviously, we can't, it hasn't been established in people who can't take nitroglycerin during the study. In patients who have stents or bypass grafts, which are probably the higher risk patients, you can't really assess. In people with any kind of motion artifacts or high degrees of calcium, it becomes somewhat problematic. So maybe in the highest risk patients where you need it the most, maybe it's not as good a technique. And of course, you have the backdrop of not having yet any prognostic studies, no randomized prognostic studies comparing the value of FFRCT versus no FFRCT. So I know some of those trials are in progress or have been designed and are in progress. So what are your feelings about that?
I think the first thing I've got to say is a big error here. I don't know why Lance Gould's slide didn't end up in my data, in my presentation, and he's shown tremendous data of the benefit of PET coronary flow reserve measurements in terms of revascularization risk. So the FFR, I think FFR has clear-cut limitations, and one thing about FFR, I think this 0.80 threshold is just not the appropriate threshold. I think Lance has shown it before. 0.75, or he thinks even down in the 0.68 level may be more appropriate. So that's not a definite gold standard. It's the accepted one, but it's not. And I just mentioned that in that FFRCT study, the Pacific trial, that if you looked at the patient who had between a 0.68 and a 0.80 measurement by FFRCT, right in that group, approximately 60% did not have less than 0.8 in the cath lab. Yeah. So there's a problem with false positives on the FFRCT.
Yeah. No, I totally agree with all of your comments. Again, thank you so much for joining us today. I know it's early in the morning in LA. Wonderful lecture, wonderful insights into where the ischemia trial fits and where really functional testing and CT fit in today's environment. And thank you so much for being our Mario Verani Lecturer this year.
It was my honor. Thank you very much, John.
Thank you, Dan. Have a good day.
Take care.